Hi, everyone. Welcome to Anesthesia Coffee Break with me, Lahir, and Stan. And today we're going to talk about all things Rotem and TEG as it pertains to this question from 2022 in the first sitting, number 4. And the question there is, draw and label a graph of normal, basic, viscoelastic test of clotting function. What information about the physiology of clotting is depicted in this graph? How will the graph be altered by hyperfibrinolysis? Yeah, wow, that's a mouthful of a
That's
question.
a big question. Yeah. And look, this was a request from a patron, not specifically, or actually was specifically a couple of weeks ago, but more so in terms of they wanted me to go through a question that's been asked over the last couple of years with a very low pass rate. So this one here had a 25% pass rate. And what I normally do, Lara, is I normally go through the exams report, and you can go through it. And the ones that are highlighted in green are the ones that I think are really important and key to add in the answer here.
Hey, and Stan, just quickly, is there any correlation between lower scoring SAQs and then repetition? Because I do remember, definitely for the part 2, I remember they repeated one of the very low scoring oxygen delivery ones into the next exam, which was directly on our exam. Is there any correlation there?
Look, I haven't done any direct, statistics to actually prove that, but I think there is an inkling that if there is a question that with a very, very low pass rate, they certainly will ask it again, especially if they think it's fair. Now, that is a caveat because there have been questions in the past that have been asked, which I think either poorly worded or perhaps asking, for a topic that might not be relevant, i.e., I think there was a question on gentamicin many, many years back, which hasn't been asked since then. And those questions there haven't been repeated since then. So there is a caveat to it. But I think also that, this question, for me, I must say to you that I did not think they would ever ask a question on TEG or Rotem. I'm going to be honest with you.
Yeah. I always thought it was very part 2 stuff. That's where we were tested on it.
I agree. And yeah, but at the same time, I think that, we have to evolve. We have to understand that I think TEG and Rotem are now almost a part of anesthesia practice, especially in metropolitan obstetric trauma hospitals. So I think it's good to know some knowledge. And look, the key today is that I know it's complex, but I'm going to try to simplify it as much as possible. Okay, and that is the really whole aim of today. Is just to really create a very simple platform for you guys to go back and understand and be able to reproduce easily. I acknowledge that it's very, very complex. And I think Lara and I, we use it. And I'm going to be honest with you, even some of the numbers I still don't understand. Do you have a good grasp on all the numbers?
Yeah, like I don't use it often enough. It's not like I'm one of the registrars on call doing obstetrics day after day or in a trauma hospital anymore. So I'm just not looking at it every day. I've got a cheat sheet that I've stored away in my notes. And I look at that every time I ever need to use it. And I mean, that's just how it's got to be now.
Same. Yeah.
So this question, so what are they saying? So it consists of 3 domains. Draw a graph of viscoelastic test of clotting function, link the graph to the physiology, and describe the effect of hyperfibrinolysis. So that's really complex. This is not an easy question to do if you haven't practiced it. The answers which scored poorly in one area could be compensated for by better answers in other areas. To pass the first section, it was necessary to produce a basic outline of a TEG or Rotem, so either one, along with some clearly labeled common indices such as R time, CT or clotting time, alpha angle, max amplitude MA or MCF, etc. Credit was awarded for including normal values. The second part of the answer needed to link the various components of coagulation process with specific phases of the graph, such as the contribution of platelets to MA and MCF. And the final part of the question required either graphical depiction or a written description of the characteristic changes seen in hyperfibrinolysis. Credit was given for an explanation of the pathophysiology and the role of aptum, but was not required to pass. Interesting. So there's more of it. So no marks were awarded for describing the process by which the graph is created or the evidence for its use in specific clinical scenarios, as this was not asked for. Simply listing common TEG Rotem parameters or pathologies without linking these to the graph also attracted no marks. So common errors, and a whole bunch of common errors here. Imprecise or incorrect labeling of the graph, lack of X or Y axes, incorrect units or numbers, directionless comments. For example, alpha angle is affected by fibrinogen, confusing hypofibrinolysis with hypofibrinogenemia, lack of.
I'm glad I've got you here, because I would have struggled to say that word.
I think I struggled a bit there. Lack of understanding regarding the contribution of specific components of coagulation to various phases of the graph, and not realizing that thrombolysis is a normal part of the coagulation process. Yeah, wow.
So look, I think this was one of the key ideas here from this question, is that you actually need to know what the shape is. And I think that I've seen so many variations of what a normal shape of a TEG or Rotem should be. Yeah, I mean, and can you describe for the ones in the radio what I've got here on the screen?
I love this. So Stan, did you come up with this?
I mean, I had to associate some of the shapes with these images here. But yes, I did sort of find all these shapes there.
This is a great mnemonic, I got to say. So the first one is a wine glass, and you can just see the normal. This would be the normal pattern, really. So normal.
It's actually not just a wine glass. It's a. I heard there's a different. This is a brandy tumbler.
A brandy.
Or brandy glass. Yeah, because there's a difference. Yeah, if you see the other ones, there's a different type of wine glass that's there. So this has to be like a brandy glass.
I think I've actually got one of these that I bought from an op shop. But yeah, it comes, it's got a nice, a fat base and a slow angle to a smaller, circle like the upper lip. And then you've got the egg shape. Everyone knows what that looks like. Got a small sausage. So what would that be, like a small wiener or a small chorizo? And then
cocktail sausage.
Cocktail sausage, yep. And then a maple leaf. If you imagine a maple leaf has a much steeper angle, more triangular shape than, say, the wine glass, which is softer angle to the opening of the glass.
Yeah, correct. And so, look, I want to sort of ask someone, one of our listeners, to sort of give us their thoughts on, if they were to draw this graph here on this exam, which one would they draw? So, Liv, out of the ones that are there, which one do you think you would draw for this question here?
For a normal graph?
Yeah, for a normal. What would be considered a normal TEG or Rotem?
I would probably either the leaf or the wine glass. It depends how fat the leaf is.
Yeah,
the wine glass. Yeah.
Yep. And you're certainly not wrong. I mean, I think that is one of the key ideas here, is that with the leaf, what would be the big difference between the leaf and the brandy tumbler?
If the brandy tumbler was really fat, then it would probably be hypercoagulable. And then the leaf, if it went quite narrow quite quickly, that would be hyperfibrinolysis. Yeah,
correct. So essentially, I think we can agree that those are sort of the two shapes that we often see represented as what's considered normal. In fact, the egg and the sausage, the cocktail sausage, I've seen as well represented as normal. But certainly it's how you want to describe the fibrinolysis that occurs at the end. And I guess it also has to do with the timing you have on the x-axis, okay? And, I think the other sort of confusing thing that you need to know about is, for Rotem and TEG, is what are the numbers that you need to know? And I'm sure you guys have seen all these numbers, and we don't need to go through it, and I'll go through it, in fact, each one specifically. But when you see it represented in this format, it can get really confusing and really overwhelming. Now, Lara, I think if you can go through this graph, this is probably one of the articles that I think a lot of people reference, their answer from, and I think a lot of sources from the internet actually use this graph here from this article in CACCP to really reference in terms of what they talk about Rotem and TEG.
Yeah, sounds good. And I just felt like a glass of water, and here is my op shop. What do you call it? A brandy tumbler?
So, yeah. Let's have a look. Hold on. Let's have a look. I want to see it.
I think that's the one. Anyway, so can you see? Anyway, that's fine. Let's go back to. Yeah, let's go.
Yeah, it's very nice.
But But yeah, so share the screen again if you would there, Stan. And yes, this is great because I mean, I think everyone's heard of the BJA education. It's now called the BJA education series, and this was all the way from 2013 and still very relevant. So this is a figure 1, typical TEG and Rotem tracings. And pretty much what we're showing here is the reaction time. So R being the time by which you actually start a clot forming. And then the next thing that you mostly look at is the alpha angle on this graph. And really that shows the rate of clot formation. You get this maximum amplitude, which makes sense that it's the maximum amount of clot form. And then you get this slow decrement, which is measured at CL30 and CL60 or LY30 and LY60 if it's Rotem. So yeah, I mean, interestingly, you've got...
And what shape would you say that is?
What shape? I mean, that looked like the tumbler.
Yeah, it looks like the tumbler, brandy tumbler. I agree. So, that's one of the things I want to point out is that, in that previous diagrams that you see, you can see that this one here, this one's a maple leaf, and this one here looks like an egg. And again, these are representation of, I think, of the graph. And I think what happens is that they're trying to describe all the numbers and what happens with each of those parameters. But by doing that, I think a lot of us take that as this is representation of normal. And I think that's one of the key points here today is that when you see a diagram that has all these parameters labeled, just be aware that it may not be the accurate representation of what's normal. I think it's fair to say that this would be considered normal. And in fact, this would be a real life example. I think this is something that you and I would see every day, not every day, but when we do obstetrics and run Rotem, this is the kind of shape that we would see, a very elongated brandy tumbler.
Absolutely. Yep. Hey, I just wanted to add that, so I grew up in a very Buddhist household. And so, like the graph of the maple leaf, it's got a bit of an angle to it. I just wanted to show you what this really looks like to me. The Bodhi leaf. So this is the leaf of the tree that the Buddha got, Prince Siddhartha became enlightened. And this is a very popular kind of symbol in Buddhist culture. And because you got this like tail at the end of it, so if you imagine like that's the abnormal sign of hyperfibrinolysis, right? So to me, that was always a Bodhi tree leaf. Yeah. Anyway.
And you just have one of those leaf, or is it, how would it be represented?
What was that, sorry? Oh, as in...
You just have one of the leaf in like with the statue, or would they be sitting on the leaf, or...
It was in many different forms, so yeah, I wouldn't worry about that. But like say this picture here, it's just a symbol of enlightenment in Buddhist culture. Yeah, so there's a bit of culture for you.
There you go. Okay, so enlightenment is essentially hypofibrinolysis. Gotcha.
Pretty much, yeah.
All right. Sorry, and so look, I think that one of the key ideas here is that when we think about these viscoelastic graphs, there are two types. There are TEGs and there are Rotems. Okay, and Lau, do you want to go through the difference between the two?
Well, I mean, why don't you go through that? That's fine.
Well, yeah. So it's essentially the way that it performs the test, and essentially a TEG or thromboelastic graph rotates the cup with the pin in the middle. And then a Rotem rotates the pin, okay, with the cup stationary. Now, the thing is why you see all these different numbers is because a Rotem has so many more additions to it. So it's got things like XTEM, INTEM, APTEM, HEPTEM, FIBTEM. Now, I don't want to go too much into detail for each one because I think the main aim today is how we're going to pass this question here. I think if you want to do well, like you want that 4 out of 5, that's when you start thinking about what does each one of those mean. And look, it's not that difficult. So XTEM is looking at the extrinsic pathway. It's got tissue factor to essentially start the coagulation cascade. When we're talking about INTEM, it's the intrinsic pathway. So it's got phospholipid and ellagic acid to activate the intrinsic pathway. APTEM has a protein to inhibit fibrinolysis. Otherwise, it's essentially XTEM. HEPTEM looks at the heparin effect. So it's got heparinase. to basically antagonize the heparin. Otherwise, essentially like INTEM. And then FibTem has a platelet inactivator. So what it does is it takes away the platelet effect. And I'll explain to you later why that's important. Because when we go through the concepts of each one in terms of how the graph is actually developed, one of the key ideas there is that platelets and fibrinogen have a very close role together. And sometimes it can be very difficult to tell which one is it. Is it fibrinogen or is it platelets? And that's where FibTem helps you out on that.
Hey, Stan, so does this mean that Rotem is far more specific for different situations? And in a sense, is it better than TEG?
It depends on how you interpret it. Like the manufacturers of TEG would argue, because they've got other parameters that I think can give you that same information that Rotem has. So it really has to do with how you interpret the information. So in other words, that Rotem has like a coagulation index, which it calculates using all the parameters that are there, which Rotem doesn't have. So each one has their different, I guess, advantages and disadvantages. But in saying that, you would argue, right, that because you've got all those XTEM, INTEM, APTEM, HEPTEM, FibTem, it gives you more information. And I think that what I'm seeing personally is that Rotem is definitely becoming a lot more ubiquitous around hospitals than TEGs. TEGs, I think when I was coming through, was probably the predominant one. But yeah, now it's Rotem.
Okay.
Yeah. And so look, this is one of the key ideas I wanted to talk to you about. I know that there are many, many ways that we can describe it, but I've summarized it, and this is my own way that I think about this, and I hope it's nice and simple, and for you to replicate and use, and you can even adapt it however you want. Okay, but the way that I think about it is how you start coagulation, what is the speed of coagulation, what is the strength of coagulation, and what is the stability of the clot. So really 4 S's: start, speed, strength, stability. How does that sound, La?
Yeah, I think that's a really good, simple way to get it through. Love a good mnemonic.
And so by understanding, what starts coagulation, what is important in terms of the speed of coagulation, what is important in terms of the strength of the clot, what is important of the stability of the clot, we begin to understand how Rotem and TEG is formed. And then we also begin to understand what factors are involved to be able to know what we need to use to fix those parameters. Okay?
Excellent. So yeah, tell us about the start.
Yeah, so the start, it's a very fixed idea. And as Lars said when it was going through, there's the R time and there's the CT time. And it's essentially the time to what we call 2 millimeters of amplitude. In TEG, it's called the R time or the reaction time. In Rotem, it's the clotting time or CT. Now, what I want you to know is that this diagram I have on the right is very simplistic, okay? One of the key things is that there are 2 different tests. And so what's a normal R time is very different from what's a normal CT time, and we'll go through that. So in this diagram here, it looks that the R and CT time are equal, but they're not. So let me make that clear. They're different tests using different reactants, and because of that, they're going to have different variations in terms of what's normal. Right? So this is a very simplistic diagram.
And because this is a real-time kind of point of care test, and in a rapidly bleeding patient, it's very important to have fast results. Is there a sense of which one is better from a speed?
Rotem's faster.
Yep. Rotem's faster. I get results on R and CT, and then all the other results faster than TEG.
So R time is TEG. So you get CT, you get the A5 a lot faster than TEG. Yeah, TEG, as we'll go through, the reaction time actually takes a little bit longer with TEG.
Oh, good to know. Yeah.
I mean, and when I say longer, it's like a couple of minutes. So I guess it really depends on how those extra minutes, how they sort of factor in to your decision making. Yeah.
Yeah. Good. So Then tell us about speed. Number 2, speed.
Yeah, so speed. So speed is the time it takes from 2 millimeters to 20 millimeters of amplitude. And in TEG, it's measured as the K time, or what's known as the kinetic time. And in Rotem, it's known as the CFT, or the clot formation time. Now, what is really, tied to this idea is what's called the angle. It's called the alpha angle. And so the alpha angle is the angle from 0 to 20 millimeters amplitude. And you can really say that the K time and the angle are actually very integrated in terms of, what they represent. In other words, if you have a increase in your K time, so that it takes longer for you to to go from 2 to 20, what you'll find is that your alpha angle will reduce. That makes sense to you, La, doesn't it?
Yeah, it feels like they're absolutely proportional to each other.
Correct. Yeah. And so that's why they use, very synonymously. And that's why the things that affect the K time will also affect, the K time and the CFT and the clot formation time will also affect the alpha angle as well.
Is one used in preference? Like, say you're making a decision. I forget what the charts utilize. I feel like alpha angle is the thing the charts utilize more.
So we'll go through it. In fact, now they don't use the K and alpha angle. They use the hybrid of it, and I'll tell you why in a second. All right.
Okay.
So the next one, the next one is strength,
mm-hmm.
And I think that this one's pretty obvious, isn't it, La?
Mm. Absolutely, yeah.
Yeah. So this one's strength is just maximum amplitude, and in TEG it's called the MA, which is the maximum amplitude, and in Rotem it's called the maximum clot firmness. Now, just quickly, I've had a question from the chat which says, is the alpha angle from 2 to 20 or 0 to 20? Now, I think it's from 0 to 20. Okay, and you can see it on the graph here that if you look at the alpha angle, it starts from 0. So it's from 0 to 20 here. All right. But the K time is from 2 millimeters to 20 millimeters. All right. Whereas the R time or the CT time is from the start to when you get 2 millimeters of amplitude. But if you look at the alpha angle, it actually starts from 0.
Yeah.
From here. Okay. Like if it was starting from 2, you would have a line starting from right here. Okay. So I hope that makes sense.
So Stan, how about?
Yeah, go on.
Oh, good. I was just about to move to the next one. How about speed and strength?
Yes. So this is what I think you and I see. So there is a measure where you can combine speed and strength, and you can see that's in between the K and the alpha angle and the maximum amplitude, and that's what we call the amplitude at 5 minutes or 10 minutes from either the end of R or CT or the start of K or CFT, or really it's basically from where the 2 millimeters of amplitude occurs. Okay, so in TEG and Rotem, it's called the A5 or A10. Now, what you and I see is actually the A5. I think that's the one that you'll always see most commonly, the numbers there. And the A5 is really a hybrid between speed and strength. And that's where you can make your decision quickly in terms of what products you need to use. And I think you sort of mentioned that as well, getting those tests back quickly.
Mm. And A10 feels like it's a more accurate representative of speed and strength. It just takes longer and often not that different. It's not like it's automatically at 5 to 10 minutes.
So that one there's at 10 minutes. I think it really depends. I think the one that is in our algorithm is A5.
Yeah,
I think that's the one they commonly use. Yeah.
Okay.
But I'm sure some studies could use A10, and in fact, you can use whatever you want. You'll see A15, A30, A60, and what those represents are the times in which they occur. All right. Okay. So we got start, we got speed, we got strength, and
how about stability? Number 4.
Stability, yeah. So last one, stability. So the 4 S's. So the fourth of the S is stability, and that's lysis. Now, I've got lysis at 30 minutes, but you can have lysis at whatever time. So, in this graph here, you've got lysis at 60 minutes as well. Okay, but we commonly see it at 30 minutes. So it's lysis at 30 minutes from the end of R or CT or the start of K or CFT, which is essentially this when the 2 millimeters of amplitude occurs. And in TEG, it's measured as LY30 or CL30. So the LY stands for lysis, the CL stands for clot lysis. You note in the diagram, I have circled LY30 and LY60. This is an incorrect diagram in the CACCP article. Okay, Rotem does not give you LY30 or LY60. The reason for that is Rotem gives you an index, which is called LI. It's an LI30 because it's a clot lysis index. So just be aware of that. Okay.
So we won't go LY30. We'll just look at LI30 or 60. Okay.
LI30 or LI60. Correct. Okay. And just be aware of that. It's talking about it. I think probably a similar management, but it's called an index. Okay.
And then the last part of stability is this.
Yeah, the last part of stability is maximum lysis. I don't think you'll see this, but it is in Rotem and just describes that it's the percentage of decrease in amplitude from the maximum clot firmness. You'll only see it in Rotem, and you can see in this graph here, the maximum lysis is this, this proportionate to your MCF.
Right. Yeah, that sounds really good, Stan. So, this is the first part done. And if I think, whatever I use in my hospital, I'm going to memorize those numbers and that system. So I use Rotem. I'll be able to draw this, tumbler glass shape. I will then have, 1, 2, 3, 2 and 3 and 4 as my variables to think about. And then I'll just put some normal values there. And that's my first part done. I reckon I could get that down for the exam in hopefully, 3 minutes. That sounds pretty reasonable.
And I think if you think of it, in those 4 things, in those 4 S's, and hopefully that is an easy way to remember it. Start, speed, strength, stability. Okay?
No, that's great.
And what we'll do now is we're going to go through some questions, which I think will hopefully really help you memorize those key ideas. All right?
Sounds good. So
in fact, why don't you ask the questions to the audience?
Yeah, what is required for the start, to start coagulation? So let's see, who's got a... So we, as we stated, this will go up on the podcast and YouTube. So anyone with their camera on, hopefully you're okay with being asked a question and for it to be on YouTube. And this will just be really a discussion. But hey, do you want to, let's go with Christine, if you're happy. Christine, what's required broadly to start coagulation?
An interaction between platelets and fibrin.
Yes. Have a think about, when you think about the initiation phase of coagulation, what is even before that?
Yeah, coagulation factors.
Coagulation factors, yeah, correct. Well done. And even thinking about it more specifically, when you talk about coagulation factors, what do you want to point to specifically that occurs at the start?
Is it the thrombin burst?
No, thrombin burst happens after, because thrombin burst, remember that thrombin burst needs to have, that cascade occurring. Okay. So in other words, what needs to occur for that cascade to start going down specifically?
You would have to, activate either the intrinsic or the extrinsic pathway for coagulation.
Yes. Excellent. Well done. That's right. That's exactly right. So what is required to start coagulation is what needs to occur at the start of the extrinsic pathway. And can I ask, you don't have to know, but do you know what other factors or what's involved to start off the extrinsic pathway?
Is the extrinsic tissue factor one?
Nice.
Yes, tissue factor. Good. So tissue factor is one, and then there's another factor.
On that side, factor 7.
Factor 7. Excellent. So it's the tissue factor 7A complex that starts off the extrinsic pathway. And that's really the most important one. But we also need to think about the intrinsic pathway as well. And do you know which one starts off the intrinsic pathway on the coagulation cascade?
I think it's 12.
Yeah, 12 to 12A. Excellent. Well done. And then where do they all converge to?
At factor 10A, they become the common pathway.
Wonderful. Correct. The common pathway. And then factor 10A binds with factor 5A, and that's what gives you that thrombin. Okay. Well done. And so knowing that, if you had a slow coagulation or slow start to coagulation, what do you think would be the issues there?
I suppose that's why with Rotem you do the IM-TEM and the APTEM, so you can, or the XTEM, sorry, so you can see whether it's an issue.
And let's not go too much into, I guess, the details of that. We'll think about it sort of at a very basic level, and then after that we'll sort of build onto it. But on the basis of what you've described in terms of what is required to start coagulation, if you saw that the start of coagulation was really slow, what does that imply to you?
Just a hypercoagulable state as a result of either coagulation factor deficiency or, for example, like an anticoagulant medication.
Good. Excellent. And so what would you do to treat that?
You could give FFP.
Excellent. Because you want to give coagulation factors. Yeah. Well done. And then the other one you can also give is prothrombin X as well.
Yeah.
Excellent. So you've done so well. So look, essentially, when we think about starting coagulation, this is called the initiation phase. And I'm really trying to tie in the ideas of the cell-based model theory of coagulation here. Okay. So in the initiation phase, you really have the extrinsic pathway being activated, which is that tissue factor 7A complex. But we also need to think about the intrinsic pathway as well, which has factor 12A. Okay, that's less important, but it's also present as well. And then they all converge to the common pathway where you get the factor 10A, 5A complex that produces thrombin. And so that if you have a prolonged K time or CT time, what you need to do is you need to treat that with coagulation factors. So you treat that with either FFP or you treat that with prothrombin X. Okay. And that's a really simplistic way to think about this. Now, I think you're going to say to me, oh, but people say sometimes to treat it with fibrinogen or platelets. Look, if you have severe thrombocytopenia or severe hypofibrinogenemia, yes, it will affect this, but the most common cause, right, is going to be low coagulation factors, or, as you said, any potential medication, specifically heparin, which reduces coagulation factor activity.
And Stan, is it true when we do the obstetric Rotem, we always find that the typical patterns are your clotting time or K time is rarely low, but it's almost always kind of fibrinogen lack and that's solution. Whereas if you have a trauma patient, this could be often the problem where you've got massive tissue factor activation, massive extrinsic pathway activation, and consumption of factors, and therefore those situations almost always need FFP and prothrombin X. Is that right? I don't know specifically in terms of the circumstances, but it makes sense to me, and I think that with trauma patients, it's very dependent because I've seen both happen in both kind of scenarios. But I think you sort of treat it on spec in terms of what you actually see from the Rotem results. I must admit I don't go in with the idea that that a certain class of patients are going to develop a certain type of coagulopathy. Yeah, that's why you're doing the test anyway. So that makes sense.
Yeah, that's right. Correct. But yeah, I think it's a really interesting point you make, and perhaps something that I think we can have that discussion in the future if we do. I guess find an article which looks at trauma patients and obstetric patients and see what kind of patterns of coagulation is more common with them.
Yeah. On to the next question. So, what is required to speed up coagulation? So I might just ask Ben, what do you reckon? What's required to speed up coagulation?
So I think you need to have adequate clotting factors and then also sufficient I don't know what you'd call them, co-clotting factors like calcium?
Yes. So I think that the clotting factors are important to start it. Now, hypothetically, right? Let's say we've got enough clotting factors to actually start the reaction. Okay, start the coagulation. So, in other words, that your K or CT time is normal. Now we're looking at speed of coagulation. So, you've got enough clotting factors. What would reduce the speed of coagulation?
So the number of platelets that you had?
Yeah, good. So platelets is one, and then what will be the other one?
Calcium or factor 8? I'm just trying to think of where we're transitioning.
So let's think about the coagulation cascade. Essentially, what we're producing after we go through the common pathway and we go, the factor 10A, 5A complex, we produce thrombin, don't we? Prothrombin to thrombin. What is the effect of thrombin?
So thrombin cleaves fibrinogen into fibrin, and then
Excellent.
It also helps to activate factor 8 to factor 8A.
Yeah, good. Yep. And it also activates platelets as well. Okay, I think you made that comment as well. So now we know that in the speed up of coagulation, this is where the thrombin burst happen. When you've got the thrombin burst, as you said, it needs to convert fibrinogen to fibrin. So in other words, if you were short of fibrinogen, you are not going to be able to speed up coagulation. Okay. And as you said, the second bit was that it activated platelets. And so if you don't have enough platelets, this is also going to slow your coagulation as well. And so this is where you sort of see where if your alpha angle is increased or your K time is increased, what you need to do is that you need to treat it with fibrinogen and or platelets. And this is where the idea of FIBTEM comes in, where you can sort of see what is it that causes the slow and the speed up. Is it fibrinogen or is it platelets? Now, which is more important here? Is fibrinogen more important here or platelets more important here, Ben? What are your thoughts?
I would be guessing and just say fibrin, but that would just be a
correct. You're correct. Yeah, correct. So in the speed, if you look at the coagulation cascade, the thrombin burst, the first thing it does, it moves, it cleaves fibrinogen to become fibrin. So that's the first step. So that's why fibrinogen is considered more important at this step here. But platelets are also important, okay? But that is second. All right, well done.
Okay, next one. What is required to strengthen clots?
Oh, sorry, I missed this page actually. Sorry, La. And then obviously we've got to discuss the treatment because this is where it's very easy. The treatment for this, if you had a prolonged K time or increased alpha angle, is to give fibrinogen either through cryo or fibrinogen concentrate. Have you used fibrinogen concentrate before, La?
Fibrinogen concentrate? I would have. It would be a while back. I think an obstetric bleed patient, but yeah, go on.
Yeah, it's only been a new thing in our department over the last year. So I used it for that recent trauma patient that I had last year, and it was actually very good. So very, very useful. But if you don't have that concentrate there, the primary place you get it from is from cryo. Okay, and then the second thing that you can also treat with is platelets.
Nice one.
All right.
The next question: what is required to strengthen clots? And so I might just get someone to answer that. Let's go with Laura. What do you reckon, Laura? What is required to strengthen clots?
I think clot strength depends again on fibrinogen and platelets. And I think
excellent.
This is in the TEG with the maximum amplitude.
Yep. And which one is more important here, fibrinogen or platelets?
Platelets.
Yeah, correct. And specifically, functional platelets. Okay, this is where the idea of where you sort of see the effect of antiplatelet therapy. You really see it at the maximum amplitude phase. All right, and so this phase here, the strengthening, is really what will be labeled the termination phase in your cell-based model of coagulation. And what it requires as you really, as you said really well, is number one, it needs functional platelets. Not just functional platelets, it's the number of functional platelets. And then the second thing you need is fibrinogen. So the treatment for this is you need to either provide functional platelets or provide a way for them to be functional again. And might be a little bit of a tricky question, but what could be a way, what drug can we use to, I guess, increase the function of platelets?
I'm not sure.
Vasopressin?
Yeah, vasopressin. Excellent. DDAVP. Well done, Shana. All right. But yeah, it's a little bit of a hard one there. So DDAVP is sometimes used to increase platelet activity.
This is quite common, right, in type 1 von Willebrand deficiency, where you've got just a total deficiency rather than a quality of it. So you can just give DDAVP and everything kind of is better.
Yeah.
Do you find
have you used it before?
It would have been a long time ago, probably at the women's. DDA, and was it type 1 is von Willebrand's disease, relatively common, whereas all the other really rare and disastrous forms of it, again, are much rarer, so I don't really see that. Yeah, I feel like we've got so much reserve with platelets that, unless you've got this patient with HELLP syndrome or some rare thrombocytopenia, really you're seeing someone who's on clopidogrel or some other antiplatelet that you have to consider giving platelets for in spite of a normal platelet count.
Well, where I think it's helpful, and you're right in terms of that, there is actually quite a bit of reserve in with platelet function, is when you're concerned that platelet function is actually not there, even despite having the adequate platelet numbers, which is why I've really put functional platelets there. And we sometimes see it in obstetrics, with preeclampsia, even, with, they don't just reduce their function, they don't just reduce the number of platelets, but they also reduce their functional platelet activity as well.
Okay.
And then, and then the second one you can treat them with is fibrinogen again, cryo or fibrinogen concentrate.
Nice one. Next question. What affects the stability of clots? And I might just get, so who else is around? Matt Avery. What do you reckon, Matt?
So I guess this, the strength of the clot is the plasmin, I guess, or breaking down of that clot.
Mm-hmm.
Yep. So enhanced fibrinolysis will affect.
Correct.
Yeah.
That's right. And so if you saw that there was excessive breakdown of clots, what could you do to treat that?
So we want to give some antifibrinolytic therapy, something like TXA.
Yep, exactly. So TXA is probably the mainstay now. Matt, do you know how TXA works?
TXA, no, I don't, sorry.
Yeah, so plasminogen, I think.
That's right. Correct. It inhibits plasminogen. You're right. And so the other one that I think that people might have heard many, many years ago is aprotenin, but that's probably come off the market now because of its adverse effects. Now, I think there's a couple of questions in the chat that I'll just quickly go through. Ben says, when you say increase alpha angle for speed, you mean a reduction? Yes, apologies. You are absolutely right. What I meant to say was a reduction in your alpha angle. So an increase in your K time would lead to a reduction in your alpha angle. Thank you, Ben, for spotting that mistake. And Anna says, in TEG, is the CL30 30 minutes after maximum amplitude or 30 minutes after the start of clot formation? It's 30 minutes after the start of clot formation, which is at that 2 millimeter amplitude. Now, just quickly go through what Matt talked about.
And just quickly, so that was the answer to that question of LI30. LI30 is from the 2 millimeters plus 30 minutes or from 0?
So let's have a look. I believe that CL30 is from the start of K or CFT. So at the 2 millimeter amplitude. In other words, So in other words, I think the assumption is that, when we're having what we call the CL30 can also be called the A30 as well, if that makes sense. But the reason why we call it a CL30 is that at this point here, what we are trying to reference is what that amplitude is versus the maximum amplitude. Now, you could argue that at CL30, you haven't reached maximum amplitude yet, which would be unusual. And that would mean that there will be some other coagulopathy going on. Okay. But yeah, good question. And yeah, it can be a little bit confusing, but CL30 and LI30 is from 30 minutes from the 2 millimeter amplitude mark. Okay.
Nice one.
Now, I want to go through normal values because I think the examiner did make some mention of that if you mention normal values, they would give you credit for that. Normal values are hard to reproduce in this exam, specifically for Rotem. I think they're okay for TEG. So I've just given you some numbers here. As you can see, there's a variation of what's considered normal. The CACCB article has some numbers, and then I've got some other numbers from another article on PubMed. La, do you want to go through the numbers and see what the differences are?
Yeah, I mean, just looking at this, it makes me think, why would I even try to remember Rotem for this exam? I mean, these angles and things are really... So anyway, TEG R time 5 to 10 minutes. That's very nice to remember there. Whereas CT for all the different numbers.
No, they're both TEG. They're both TEG, La. So these are actually the same test, but I'm giving you two different numbers for the same test, which is why you can see how confusing it is. Because wait till you see the next slide for Rotem. That's even, that's even more crazy.
Oh, sorry. Yeah. I was looking at the next slide already. Yeah. So we've got here 5 to 10 minutes and 4 to 8 minutes. I mean, these are in the realms of similar. So,
Yeah. So I can ask you as a strategy, right? What would you do if you saw this? If you've got an article which says 4 to 8 minutes, there's another article which says 5 to 10 minutes.
Yeah.
What do you do to bring to the exam?
Examiners know there's variability, or they should know there's variability. So I would pick one and just memorize it. I think close, if there's variation in something and it's not mathematically necessary to be correct, then you just pick one and memorize it. And then what do I memorize? I memorize the one that makes the most pattern sense. And so you may choose 5 to 10 because, 5 and 10, or you may choose 4 to 8 because then the next one is 1 to 4. And then 4, 7, 7, 4. That's a nice little pattern there that you can memorize.
That is a nice pattern. I agree. I spotted that too.
Yeah. So really, I'll do whatever is easy to memorize that makes most mathematical pattern sense. And then I don't even think you'd go as far as needing to reference this stuff. That's just wasted memory. Examiners don't expect that. If you're a bit, if you're a bit good at memorizing stuff and it just comes to you, great. That could be impressive. But I would just remember the one on the left because that makes the most pattern sense to me.
Yeah.
Is that what you do?
I'd agree. Like the ones on the left, actually, that you can actually find a pattern on. But I think just be aware of the one on the right, and also maybe perhaps one in your institution as well. You may sort of see it a little bit different. Okay. And then the LY, the lysis 30, what you'll see is that what's normal is that you should only see a reduction of 0 to 8% at the 30-minute mark. Okay. And so that I think you might sort of see another one at 3%. I think there have been studies that have shown that in trauma, if you exceed 3% lysis compared to your maximum amplitude, you consider it high risk and you should probably treat that. So you might see some even more conservative numbers. Mm-hmm. Now, there's a question in the chat. When measuring MCF, maximum clot formation or maximum amplitude, is the measurement the entire amplitude of the Rotem TEG graph or to the 0 axis half amplitude? Yeah, good question. I think it's the whole amplitude. So I think it's top and bottom. Okay. And the reason for that, I say that is...
Just quickly, when you look at for stability, it says it's just got a diagram that shows arrows, from the center.
Oh, yeah. Yeah, correct. In fact, I would say, sorry, it's probably, from the 0. So from halfway. So I think maximum has to be from the 0 point all the way to the top. And if you see this graph here, I think what it's showing is that maximum amplitude is from 0 to up, and then this is the MCF is from 0, and these are absolute values here.
And your slide showing Oh, actually, that's interesting. Look at your
but because I think what it's showing is that if I was to just edit this, I think this is why I was confused.
Stand. Before you do that, what are the numbers to know? So slide, was it 6 or something? What are the numbers to know? It may be different. So MCF may be different to MA. Keep going up. What are the numbers to know slide?
Oh, what are the numbers to know?
Slide 6 or so. Keep
this
going
one here?
I don't know. Keep going all the way to the top, like your slide number 6.
Oh, slide number 6. Yes.
Yeah, that one. It may be different. See how it goes MA versus, MCF. They've actually got a different definition. One might be the whole amplitude, and the other one might be from 0 point. Just based on.
Right.
I'm not sure.
Okay. Yeah, not sure. Interesting. So maybe TEG, when they go maximum amplitude, is for the top and the bottom. Yeah. And then maximum clot firmness is from the 0 point. That's a good point. I'll need to find that one out. Yeah. I mean, this one here, this diagram here from the CACCP article is probably not sort of instructive on that. I guess what we can do is, if we can look here, the MCF, so this is for Rotem, and the MCF is 50 to 72. So that's very close to maximum amplitude. Wouldn't you agree, La?
Yeah, and the only problem is the way the solution is and the standardization. So even though the numbers are the same, I don't know, maybe they are talking about different definitions of those points. Yeah, again, I don't know. Sorry.
Yeah. I mean, going by this, so MCF is measured, in fact, maximum clot firmness, I think it's still measured in millimeters, 50 to 72. It's just a different name for it. And if it's 50 to 72, it's very close to maximum amplitude in TEG. Right. So I think my provisional hypothesis, and if anyone knows different, please send us an email afterwards or put it into the chat. If maximum amplitude is from top to bottom, or maximum amplitude is from the halfway point. I think that's a very, very,
and to be honest,
question.
It's a subtle point as well. Like, you put these numbers down, you draw the diagram. I don't think it's going to matter for the exam, but yeah, for your own learning. I mean, we just read what the numbers say off the chart, off the computer.
Yeah. Yeah.
Very good.
Now I wouldn't memorize Rotem, okay, for this specific reason that there are so many different tests in Rotem. There's XTEM, INTEM, HEPTEM, APTEM, FIPTEM, and all of them have different values. So I think it's a little bit more challenging to memorize Rotem, and I would just memorize TEG, and I think that's okay.
It's funny how, like, even looking back and just trying to remember this number, it's actually quite easy to remember. 4 to 8, 1 to 4, 4, 7, 7, 4, 50 to 70 or something like that. Like, once you have a pattern, it's so easy to remember.
And that's for TEG. And then the challenge now lies, because you've done that so easily, now to memorize Rotem.
Yeah, that's great. Easy. That photograph memory.
Yeah, no, this one here, I think it's a little bit more challenging. And look, for us, so these are the ones that I think you'll see in our practice, in our institution. And shout out to WA. I think this is based on the King Edward Memorial Hospital numbers. So I think that if you do have a WA examiner, I think, use these numbers. And so the numbers that are important there, and I've really summarized some key ideas here. You can see on, if you have it. In fact, what we should do, Lara, is I'll send it to you, and then we should definitely attach it to this presentation here. But if you actually see it on the algorithm, it's a lot more complex. But I've just picked out some really interesting ones, which is that XTEM CT, the normal one is less than 80 seconds. You can see how that's very different from your K time. It's a minute 20 versus 4 to 8 minutes. Oh, sorry. Sorry. When I say K time, I meant R time, because this is the start of your coagulation. So in TEG, your R time is 4 to 8. And here, XTEM CT, which is analogous to your R time, is less than 80 seconds. Mm-hmm. And then what Rotem has instead of alpha angle firmness and, clot formation and your maximum clot firmness is that they've got A5. So what they say is that what you want your XTEM A5 to be more than 35 millimeters and your FibTEM A5 to be more than 10 millimeters. That's considered normal. And then the last one for fibrinolysis, which is clot stability, is that you want your XTEM maximum lysis to be less than 5%. So yeah, interesting. So you can see how that they've adapted a lot of the numbers that we talked about, and instead of looking at the alpha angle, the maximum amplitude or maximum clot firmness, they've used A5 instead, which is that hybrid. But you can see how they go through all those 4 things I talked about. So you're talking about what starts off coagulation through the XTEM CT, what speeds up, and what determines the strength of coagulation, and that's determined through the XTEM A5 and the FibTEM A5, and then what determines clot stability, which is through the XTEM maximum lysis number.
Excellent.
Does that make sense to you, La?
Yeah, and again, I mean, it makes sense, and I think the value of it is, it's good that it makes sense, but practically, I end up just having to look at the graph and the context, really. But for the exam, learn some numbers, great. Just add it to the pile of numbers you've got to learn.
Yeah, and so look, I put that there just as a slide that I don't think that if you don't remember the numbers, I don't think it matters that much. I think as long as you know the sort of the key ideas in terms of how the diagram is formed, with the start, the speed, the strength, the stability, I think you're on your way to definitely passing this question here.
Yeah, nice.
And this was the graph again. I just wanted to show you that it's a very simplistic graph and that the R time and the CT time are different. Okay, so that the R time for TEG is 48 minutes and the CT time has to be less than 80 seconds or 83 seconds if you see some other different algorithms there.
So for the next few slides, Dan, so we're pretty much going to go through different normal versus pathological states. Is that right?
Yeah, correct. So I've got a normal TEG here, and I thought what would be really interesting to do, just to consolidate all the information that we have here, is to have a look at some different TEG graphs and see what we think the pathology is. All right. So I've put the reference one on top there.
Beautiful. And just for everyone listening, the reference one just looks like a nice, essentially a cylinder. It has a nice amplitude rate, easy reaction time, and nice max amplitude that doesn't drop off. Whereas the second one here, the start is a bit slower, the speed is slower, and then the strength of the max amplitude or MC is slightly decreased, but the stability is normal in this one. So what do you make of that?
We'll ask the audience on this one.
Yeah, sounds good. Let's see. What do you reckon, Olivia? What do you reckon about this?
So you've got an increased time to start and a decreased speed. So I would think that's probably something to do with your coagulation factors being decreased.
Good.
Yeah.
And I guess the question is why would you be less inclined to say it's platelets and fibrinogen?
So the strength, slightly decreased platelets.
No, I'm going to tell you, Liv, you are right. This is primarily to do with coagulation factors. Yeah. And the question is why don't you think it has primarily to do with platelets and fibrinogen? You mentioned it.
Yeah, I mean, if it was platelets, the maximum amplitude, the strength would be decreased more.
That's right. Correct.
So it makes me think less likely platelets.
And more likely coagulation factor. And know that they are interlinked. Everything is interlinked. So in other words, that if you've got low coagulation factors, ultimately it is going to affect the way that your platelets function, as well as the way that fibrinogen becomes fibrin. All right, and that's why the strength is slightly decreased with a coagulopathy. And what would be, I guess, a cause of this?
You could be on some anticoagulation. medication.
Yeah. Excellent. Well done. Good job.
Excellent. So the next one we've got here. So again, the start here is normal. The speed is slower. The strength is definitely decreased, not just slightly decreased. So the max amplitude is less, but it doesn't drop away. So the stability is normal. What do you make of that? And might go back to Ben.
So I would think that that would be a reduction in both platelets and clotting factors. So similar to what Olivia was saying before, where you've got a slower start, which would be clotting factors primarily, and then the platelets as well as impacting on the firmness of the clot. I still work in Rotem, sorry.
Yeah. So why did you say clotting factor?
Because the speed's slower. So that's why I thought clotting factors, although it does look like it's got a similar alpha angle. So it might be, it may not be clotting factors, it may just be a platelet deficiency.
Yeah. And remember that if it's, what else is tight with platelets?
Sorry, the start's normal. Yeah, it's initiating the clot.
Yeah, the start's normal. So you know that the start's normal. So you know coagulation is
Hey, Stan.
theoretically normal because that's your start, but your speed is slow. And yes, it's a platelet idea, but also what's the other idea that we also need to think about as well? Yeah. Sorry, Lau, were you saying?
I know you just cracked.
Yeah, fibrinogen, exactly. So, I was just coming in and out, was I?
Yeah, but that's all right. It's back to normal. I'll flag it if it happens again.
Yeah, apologies. I think someone was trying to give me a call. That's all. So, yeah. So you're absolutely right. So the two things here are going to be platelets and fibrinogen. All right, and it's very hard to tell the two apart unless you use Rotem, where the FibTem excludes platelets, and then that way you can tell between the two. All right. Well done.
Okay, next one. So this one is definitely one you don't want to see. So here the start is normal, the speed is normal, and it looks like the strength and the max amplitude initially is normal, but you get this very sudden drop away. So very, wrong one. Oh, yeah.
Sorry, no, you're right. Sorry, fat fingers. I'm not used to presenting and discussing a podcast at the same time. Apologies.
So as we were saying, the strength is normal, so that max amplitude is normal, but the stability falls away rapidly, so it's decreased, and you can see a very, very sharp drop away with a very elongated tail, kind of like the Bodhi leaf. What do you make of this, Christine?
So I think this is consistent with hyperfibrinolysis.
Yeah, correct. Well done. And how would you treat this?
You could give TXA.
Correct. And what would be some of the causes of this?
DIC, like a consumptive type coagulopathy.
Yeah, you can see it in DIC, and also if you can also see it if someone's been given fibrinolytics as well, electrogenic as well. Well done.
Excellent. So this next one. So this is quite a kind of a fat trace. So you've got a start, which is faster, so short R or K time, speed, which is faster, so max that alpha angle is higher, and then the strength is increased, so the max amplitude is higher as well, but the stability is normal. So essentially a square shape the whole way through. So what do you make of this? And I'll just ask Laura again.
I'm not too sure, but going off first principles, it seems like a hypercoagulable state.
Well done. Yeah, excellent. I mean, and I think that's one of the key things. You came in with this uncertainty, but you've made the right application of the concepts there. You've gone, what can cause my my clotting time to be faster? Well, increased clotting factors or increased clotting factor functionality, which means that they're hypercoagulable, and that results in increased speed, increased strength as well. Okay. Hold on. Can I ask you, where would you see this? Quite interesting.
Going off, just having a guess. So hypercoagulable states can be seen in physiological states and pathological states. So things like maybe pregnancy, but I'm not sure, or like malignancy. I'm not sure.
Have you seen these shapes before, Lara?
No, I haven't in real life. So no, we've never done it on, say, like I was just trying to work through myself thinking, where would this be? And maybe like protein CNS deficiencies and lipid syndromes, maybe. But
I'm sure there's some pathological conditions where you see it. I've seen it heterogeneically where I've, and I say in inverted commas, over a trauma patient just with excessive blood products. So I've been too efficient with my blood product giving on a patient, and I've actually seen this graph being presented.
I've seen it in pregnancy as well, if you do it just before delivery, because they've got lots of fibrinogen on board.
And that makes sense as well. Yep.
Excellent.
And then Susan, how about this graph here? What do you reckon about this one?
Actually, we'll just describe it for everyone as well. So
Sorry, I couldn't have said anything.
Oh no! Wait, hold on. Let we need to describe it for everyone who's listening to the podcast.
So this one looks a bit like a bottle, like a beer bottle, maybe, where the start is faster, the speed is again faster, so a very sharp up alpha angle, or rather large alpha angle. The strength is increased, but the stability it holds for a bit of time and then it drops off to make like a bottleneck appearance. So Susan, go for it.
I'm not sure. So just describing what you see, the dominant effect is the fact that it's fat and tails off faster. So you're starting off with someone who's slightly hypercoagulable and then breaks up the clot a bit prematurely. So would you see something like that in DIC? But I'm not sure.
Perfect. Yeah, exactly. So this is, I think, what they call DIC stage 1, which you don't want to get into, because pretty much this is what happens straight after.
What's next? Just showed now is the second, or the later phase of DIC. So this is start is slower. You've got a massively long K or R time. The speed is slower. It's a very thin. It is like one of those party balloons that the make shapes out of.
Oh yeah,
but, like elongated. So the max amplitude is significantly decreased, and the stability is kind of.
There's no clot.
Yeah, there's no clot. So there's a proper way.
Stability is not a problem at all. Yeah. But this is stage 2 DIC. That's bad. Yeah.
I hope you never see that, right? That looks.
Hope to never see that at all.
Excellent, Stan. I learned so much from that. It's been a long time since I've looked at TEG and Rotem, except out of a cheat sheet, which is practically what a lot of us will do. But that was such a great sample, Stan.
So I hope that gives you guys, I think, a framework to build on. Build on your knowledge. I think you can definitely add a lot more, concepts to what I've presented today. But hopefully that gives you a really sort of good framework. And I think, if you can reproduce all that in the exam paper, I think it's a solid 3, definitely pushing to a 4. And obviously, if you include some of the other concepts related to Rotem, that's when you can get that 5 out of 5. But that is extremely challenging because of the numbers involved and the different variations involved.
I just want to say I'm just really impressed with everyone answering those questions, because they're not easy questions, and even working from first principles, a lot of the time you guys were just doing exceptionally well with that. And I'll definitely remember this start, speed, strength, and stability type framework. Because and
that's the first time you've heard of it too, isn't it?
The 4 S's of Stan, or maybe the 5 S's. It starts with Stan. And Stan's 4 S's. And I love it.
Yeah. Start, speed, strength, stability.
Beautiful.
What you need to pass this exam too. Just think of it that way.
That's right. This
start well. You need to have the speed, you need to have the strength, and you need to be stable.
Just so poignant, Stan. This is a life in TEG and Rotem. Anyways, that's pretty good.
And Susan, I hope I answered your question. I think you were pointing out to that picture in 6. Just know that I think sometimes some of the diagrams that are there that you'll see out on the metaverse, they may not be perfectly right. The information I've sourced is all the ones that I've referenced from. So hopefully that makes sense. And honestly, that is also why LY30, what is considered normal, is 0 to 8%, because 30 minutes after, the start of 2 millimeters of amplitude, very normal to not show lysis at all. Okay.
Excellent. Hey, should we sign off, Stan, and then we can get some questions answering after we sign off?
Yeah, absolutely.
Hey, thanks very much for watching and listening. Anesthesia Coffee Break, and thanks very much for everyone who volunteered answers. That's really, really appreciated to keep this really interesting and also challenging. So, please share with anyone who might be interested, and we'll see you all next time. Bye-bye. Now, what's new with ABCs of Anesthesia is that we're forming a whole bunch of very comprehensive courses for every stage of your anesthetic journey, from medical student to procedural skills, from foundations in anesthesia, as well as really important exam lectures and clinical anesthesia courses as well.